Oh, good morning. There's my slide. So first, I'd like to thank Dr. Ganzini and the organizing committee for inviting me. And I have to say, I'm not 100% certain, but I think I'm the only RN who is speaking over these 2 days. So I do feel the burden of representing the several million. Oh, there's some in the audience. Yes. Okay, good. Thank you. So, yes, I'm from Oregon. I'm wearing my Oregon hat today, but I'm also the executive director of the Washington State Hospice and Palliative Care Organization. But most of the information I'm sharing today will be from Oregon because I have more experience in Oregon. So you may know, of course, that Oregon has a lovely coastline and we have those Cascade Mountains, including Mount Hood. But what you might not know is in my neck of the woods, which is Corvallis, Oregon, we are the Christmas tree capital of the world. So if you are someone who celebrates Christmas and buys a Christmas tree every year, it maybe came from across the road from where I live, because I'm fortunate enough to live out there. So my background is, as I mentioned, I'm an RN, and I've worked in hospice for 32 years. I started out as an intensive care nurse, and there are a lot of former intensive care nurses working in hospice, as most of you probably know. And I think it's the feudal treatments that you see being undertaken in intensive care units all over the country, maybe not so much anymore. And then I've worked in home health and hospice, as I mentioned, for 32 years, and I was director of a hospice program for 15 years, including an inpatient hospice facility before taking my current position about 3 years ago. And I personally am neutral on the Death with Dignity Act, as it's called in Oregon, and our state organization is neutral. But my experience, as a hospice director, we did have a patient shoot himself, and it was actually when Death with Dignity was legal. But certainly I compared and contrasted the family's response to that with Death with Dignity deaths. So that does color my perception. So let's move on there. So I'm just going to gloss over this because I know Dr. Katrina Hedberg is here and she's going to talk more about data. And the 2017 report was just released on Friday. But as you can see, it's really a very small percentage of deaths that occur with the Death with Dignity Act in Oregon, given we have about 30,000 deaths per year and about 20,000 on hospice. And so again, I'm going to gloss over that. And so I'm really talking about long-term care and death with dignity. And as Dr. Lynn pointed out to me, 50% of long-term care occurs in the home under home health or hospice or private duty care or no care at all. But I just wanted to show that a great majority of deaths under death with dignity do take place in a patient's home. And we'll talk about that more in a second. And most patients, as has been previously mentioned, are enrolled in hospice. And I do want to mention a couple things. I did an informal survey, just sent it out on February 1st in anticipation of my talk today. And so I offered with Dr. Campbell to work with him to update the research that's been done 10 and 15 years ago in Oregon and Washington. And 100% of hospices who respond, and again, it was only 22, I had only 22 responses. There are about 65 or so hospices in Oregon. They will keep patients on service. I do know anecdotally of one hospice in Eastern Oregon that will still discharge a patient who expresses interest in death with dignity, and I think that's unfortunate, but certainly we have evolved over the years. 95% of hospices will allow their staff to provide verbal or written referral information, and that's a change that's evolved over the years. And 35%, again, this was just my small sample of 22 who had responded in the first week, 35% said they would allow their physicians to participate, leaving it the choice up to the physician. And then they also, of this sample size of 22, 75% said they felt their hospice staff were neutral and would not request to be reassigned if they were visiting a patient who expressed interest in death with dignity. And so this is just a snapshot. And again, Dr. Hedberg is going to go much more into the data. The data on the right is from the CMS hospice provider use files. So it just compares a little bit, to the level that the data was available. So again, as has been mentioned, Oregon is a predominantly white state, and the majority of patients who pursue death with dignity are very educated. And a higher percentage have cancer. Overall in the state of Oregon, only 30% of our hospice patients have cancer. So what I really want to focus on in the barriers to use of physician-assisted death in long-term care. And I did consult with End of Life Choices Oregon because they're primarily the group who provides volunteers anymore to go into the home if someone is interested in pursuing death with dignity. So they contributed to this. So certainly if you don't have an attending physician, that makes it difficult to pursue physician-assisted death, and this happens to hospices probably all over the country, but certainly in Oregon. We think nowadays that everybody has an attending physician, but that is simply not the case. And there are some faith-based providers, as Dr. Fromey mentioned yesterday, especially in the Portland area, who will not allow their physicians to participate. As I mentioned, 35% of the hospices in my sample will, but that means 65% will not. And then if you don't have friends or family who can be a witness, that can make it a challenge. And there are some, particularly in long-term care facilities, there are some rules about who can witness if there's an employee. It has to be a social worker, et cetera. So there are just some hoops to jump over. And especially in nursing homes or long-term care facilities, mental capacity is not always what it is in the general population, so that can be a barrier. And then continuing, waiting too long. And I have a colleague, a physician, who says the majority of patients who come to him requesting death with dignity, and he is willing to participate, wait too long. And so that's a problem. And in a nursing facility, if you wait too long and you're already sort of borderline in terms of capacity or the ability to self-medicate, that can certainly be a challenge. And then there's the not in my backyard philosophy. And there are 4 hospice inpatient facilities in the state of Oregon, and there are 10 in Washington state. And to my knowledge, none of them allow patients to ingest the medication on site. And in my recent survey, 61% of the hospices reported that they knew of no facilities. And I have that more on the next slide. But the cost of the medication, as has been mentioned, can also be a barrier. And then this is from my survey. So again, almost 62% said they didn't know of any facilities in their service area who would knowingly allow a patient to take the death with dignity medication. And there are no official lists kept. I get calls and emails about that occasionally. Where's the list of the participating facilities, the participating providers? Well, we don't keep a list like that, and we'd have to update and maintain it all the time, and we just don't. I know that End of Life Choices Oregon will call facilities on behalf of patients and find out. So if someone's at home and willing to go, wanting to go into a facility, they will do that groundwork. And then I'm just going to end with some opportunities for research, again, based on my 30-plus years experience in hospice and the 20 years this has been legal. So do patients complete it because symptoms are not being managed? In the majority of time, we don't find that to be the case. But, there's not a lot of research. And is there a difference in the grief process for survivors of a person who completed physician-assisted death compared to survivors of a natural death? And how does caring for patients who pursue physician-assisted death impact healthcare providers? Does it contribute to more or less burnout? And what is the impact on families compared to when patients use VSED or a more violent cause of self-inflicted death? And what is the impact on patients and families if their hospice program does not allow them to be present in the home? And so this is the survey results about the majority of hospices do now allow their staff to be present in the home, and some allow them to be including in the room, almost 48%. and I wanted to get to the end before the dreaded beeping red light. So, in closing, my contact information, if you Google Oregon Hospice Association, you can get connected to me. Thank you very much.